So the question starts as follows. Can the findings be generalized to primary care or secondary care setting? And the title of this presentation would be Adapting the Clinical Research Model to Clinical Practice with, and the limitations of a clinical research problem in translation. So to answer the question, can the findings be generalized to primary care or a secondary care setting? Yes, I agree that the findings in the article may be applicable to primary care and secondary care hospitals. The counter-argument by a person differing in opinion would likely be as follows, or let's title it Limitations of a Clinical Research Problem in translation. So the diagnostic study described where antibiotic decisions are based on a combination of detailed clinical examination and specific laboratory tests is governed by a strict research protocol. Replicating the success of this clinical research study in primary care health hospital setting or a secondary care setting involves significant challenges related to resources, environment, and personnel. The core limitation is that the clinical research study likely established efficacy. To say efficacy, does it work in an ideal setting? While in the primary healthcare setting, demands effectiveness. To say, does it work in the real world? The success of the clinical research protocol is constrained by its external validity and the logistical feasibility of maintaining protocol standards under routine care conditions. And the main challenges related are as follows. Let's look at three of them. The first one, the difference in resources and the ability of busy primary care staff to adhere to the strict protocol necessary to achieve the clinical research study outcomes. And two, a resource gap at the primary point of care in terms of diagnostics and the available resources to carry out diagnostic tests. And the third would be the ethical dilemmas physicians face when balancing a research-based protocol with parental expectations in a primary care setting. So from there, we can look at the replicability in primary care hospitals, which would be the ability to replicate the study's results in a primary healthcare setting is fundamentally limited by the difference in infrastructure between a clinical research setting and a routine primary care primary care hospital. And the reasons would be because, of course, one, resource and infrastructure disparity. Availability of specialized laboratories in a clinical research study often utilizes high-sensitive, rapid, and sometimes costly laboratory tests, such as what known as PCR, the polymerase chain reaction, specific biomarkers, or high-throughput microbiology tests. Many primary care settings, particularly low-resource settings, may only have access to basic hematology and culture facilities. If the study's success depends on a test that is unavailable or has a low turnaround time in primary healthcare, the protocol cannot be truly replicated. It will be difficult to demonstrate the same results. And is what they call equipment calibration and maintenance. In clinical research settings, the main strict equipment calibration, they have main strict equipment calibration and quality control, as opposed to the primary healthcare setting. Labs may have less stringent standards or older equipment, potentially introducing variability and measurement error or diagnostic drift into the results. So that was in terms of resources that hinders replicability in primary care hospitals. And second, apart from resources, there's also what we have known as personnel expertise and protocol adherence. Standardization of clinical examination. In the clinical assessment the initial clinical assessment in a research study is performed by investigators specifically trained and standardized on the research protocol. However, in the primary care the hospital setting, the clinical examination depends entirely on the varying skills, experience, and adherence to specific guidelines of the treating physician or nurse, leading to heterogeneity in the input data, the clinical examination of fever and other symptoms. Adherence to protocols, especially complex protocols, can also be a hindering factor. Research protocols demand meticulous documentation and step-by-step adherence. And primary care hospital staff dealing with high patient volumes and competing priorities and many other impediments may struggle to maintain the structure adherence levels necessary to reproduce the clinical research outcomes. So that is regarding replicability. And let's go now to efficiency in primary and secondary care hospitals. So efficiency is measured by the cost, time, and human resource utilization relative to the clinical benefit in the primary and secondary care hospital settings. So with cost, the specific laboratory tests required by the research protocol, such as newer diagnostic kits, may be prohibitively expensive for routine primary care health hospital budgets or for the patients themselves. High costs reduces efficiency. And there's time. If the laboratory tests have a long turnaround time, some can even go for more than 4 hours in terms of turnaround time. The child may receive empirical antibiotic treatment before the definitive results are back, defeating the purpose of the diagnostic algorithm, such as delaying treatment is also a risk. So slow turnaround time undermines the immediate clinical utility. Then there is workload. Implementing a complex diagnostic algorithm adds to the existing workload of primary care health staff, requiring additional time for training, sample handling, and documentation. And that results in increased burden, diverse resources from clinical care. So they focus more on replicating the clinical research setting as opposed to continuing to care for their own patients that they have been assigned. So we'll now look at the instances of divergent clinical outcomes or a failure of replication in terms of failure of replication of the clinical research study setting. So the clinical outcomes may not be achieved due to factors that interfere with the diagnostic treatment chain in the primary hospital care environment. Non-protocol treatment deviation, what they call a pragmatic drift, medical, legal, and parental pressure in a real-world primary care hospital, where a physician may be pressured by concerned parents or be influenced by medical legal risk to prescribe antibiotics despite a low-risk diagnostic result from the primary health care. So this deviation from the researcher's non-antibiotic decision directly lead to a different outcome, which would be, of course, a higher antibiotic use, increased side effects, and the other possible outcomes, including even antibiotic resistance and the like. And then there is what they refer local epidemiology. In the clinical research study may have conducted in a region with low rates of drug-resistant pathogens. If the primary care hospital is located in an area with high rates of resistance, the standard antibiotic recommended by the protocol might fail, leading to divergent and poor clinical outcomes, what they call as treatment failure, which is, of course, will be a failure of the replication of the clinical research study. And then there's patient management and follow-up. So loss to follow-up. A crucial component of a research study, of course, is meticulous follow-up to track the true clinical outcomes, such as resolution, relapse, long-term complications. And in primary care hospital, populations often have higher rates of patients who fail to return for follow-up, making the successful measurement of the intervention's impact on clinical outcomes impossible to confirm or replicate. And remember also that in a clinical research setting, the investigators are more rigorous, and they do more rigorous follow-up of patients, unlike in a clinical setting, in a normal clinical setting, like in a primary care hospital. Then there is the core interventions. In the primary care hospital, patients might receive other treatments, e.g. traditional remedies, over-the-counter medications that were excluded or strictly controlled in the research environment. These core interventions can confound the results and lead to unexpected outcomes. So, that's the end of my presentation with regards to adapting the clinical research model to clinical practice and the limitations of a clinical research problem in translation, in terms of translating it into a primary care or a secondary care setting. Thank you.